So we are starting in 3, 2, 1. So we are live now.
Good evening, friends. Welcome to the Thursday evening webinar on Unique PG Track program. 22nd webinar on approach to valvular heart disease, what everyone should know. So we are actually restarting and revisiting the common cases that are often asked in exam. And to start with, one of the most common things is valvular heart disease. We'll be having different presenters, different approaches, how and what we should know about valvular heart disease. I have the privilege of having Professor Sumodh Kurian and Professor Girish Ampi as panelists with me today. And we have the pleasure of having Dr. Kamal Sharma. Earlier, he had talked about rheumatic fever, which you can visit on the our YouTube channel on PG Track CSI Delhi branch. And today, Dr. Kamal Sharma has kindly agreed to speak on approach to valvular heart disease. So over to Dr. Sumodh to start the session. And if you have any questions, please type them in the chat box. We'll be happy to take them and discuss them with Dr. Kamal Sharma. If you have further questions or any clarifications or sessions, please mail us on the said email pgtrackcsidelibranch@gmail.com. Many of you are asking that if the lectures are missed, no worries. The same email is also the YouTube channel of this particular series. So over to you, Dr. Sumodh, for this wonderful session.
Yeah, as we all know, the most common long case, that is exam is going to be a valvular heart disease, and one need to be very familiar, as to how to approach, how to present the diagnosis, how to assess the lesion severity. And we already had some lectures before, but we are giving lectures from by very eminent teachers, so that you can know what all possible questions can come from this particular topic. And Dr. Kamal had taken a very beautiful lecture on acute rheumatic fever previously, and today sir is going to teach us how to approach valvular heart disease and how to assess the lesion severity. We welcome Professor Kamal, who is a interventional cardiologist at UN Mehta College in Ahmedabad, to come and give your lecture. Welcome, sir.
Good evening, everyone. Thank you, Professor Sumodh, Professor Mohit Gupta, my friends, Dr. Girish. What I'm going to start and talk about, because 1 hour I felt is not the time enough for talking any topic for that matter. But what we can do is, I'll try to just go about approach that a student is supposed to have when he's approaching a case of valvular disease, especially a multivalvular disease, and how you can clinically approach it, and as to arrive your diagnosis as to what you're dealing with, which is a dominant lesion, how severe it is. This differentiation of dominant lesion, because most of the times, most of the fellows are able to make a diagnosis, there is no problem with that. But when it comes to justifying which one is a dominant lesion, whether it's the aortic valve or the mitral valve, or is it the stenotic valve or the regurgitant valve, because that's going to also change the line of management, and also it has to corroborate with your X-ray, ECG and echo findings. So your examination findings should start right from the history. So that's what we'll touch upon. The first important aspect would be the cardinal symptoms and the origin, duration, progress, as we know. Now, we know that the commonly asked questions is, once you mention certain symptomatology, you'll be asked, like suppose you mention angina, you'll be asked what are the common causes of angina. So we need to stick around and be tracking, and Viva should be around what you are going to answer. If you're going to start with aortoarteritis as one of the potential cause of angina in a cardiac patient, then your valvular heart disease remains on one track, and you'll end up answering all on Takayasu's disease. So answering also has to follow a suit and has to follow a pattern where you want to lead the examiner, or what you're going to talk about, and also about the commonalities of the things. The common things should come first. The rarest of the rare things should be answered very rarely. They should not be answered up front. So common cause of chest pain should start with the ischemic heart disease, pericarditis, mitral valve prolapse, dissection aorta. You can then go on to say how mitral stenosis can also have an angina. So similarly, you sometimes maybe ask a combination of symptomatology. What are the causes of, say, dyspnea with chest pain? In which case, again, you'll have to think around that the patient has an LV dysfunction, or patient has got aortic stenosis, or there are certain other disorders which are non-ischemic. So this is very often asked, what are the non-coronary causes of angina? So that symptomatology also makes an important understanding of approaching a multivalvular case. Now, very often you may be misled or you may be asked to understand as to what makes you think that what you're dealing is primarily a cardiac dyspnea. And they're simple, basic, fundamentally medicine questions, which these are. We need to know certain important aspects which help us to differentiate respiratory from cardiac disorder of breathlessness. The commonest of them being that the breathlessness precedes cough in cardiac disorder. This is primarily driven by interstitial edema first, which impairs the ventilation perfusion ratio or causes a VQ mismatch. And then you will have the pink frothy sputum once the alveolar edema develops. While in respiratory disorder, it's the irritant or the precipitant of the respiratory or bronchial asthma, which first causes a response in form of a cough. And once the bronchoconstriction ensues, then the dyspnea develops. So this temporal relationship between dyspnea and cough can sometimes help you to differentiate. But very important is, of course, the classical PND. But of course, there are some mimickers, as they know, in respiratory disorders, like the obstructive sleep apnea, rarely bronchial asthma, which can mimic PND. But a classical PND of the 15-20 minutes difference of 2 to 3 hours of after going to sleep, not lying supine, need not be associated sharp at the early morning, like 3 or 4 o'clock, which you get in bronchial asthma, can help you differentiate what you're dealing with. Very importantly, the type of expectoration. But one distinct feature that is always present in cardiac dyspnea is a sympathetic tone, high sympathetic tone. And this high sympathetic tone will be manifested by examination or presentation in form of diaphoresis and palpitation. So these two things are usually not present in respiratory disorder unless like a patient is already on a beta-2 agonist systemic therapy, which is rare nowadays, barring certain commonly prescribed cough pill syrups, which still contain salbutamol as a preparation. Barring those, systemic beta-2 agonists are not given, and hence you would expect when you find a patient with dyspnea with a heart rate of say less than 100 with dyspnea, you're probably dealing with a cardiac disorder rather than a respiratory disorder. If it's less than 100, it's respiratory. If it's more than 100, of course, it's very likely to. But again, it's this distinction is not very clear cut. You have to corroborate with other findings like past history, personal history, and family history. Now, you would often be asked what causes acute deterioration in a patient of valvular heart disease. Now, sometimes a previously stable patient can deteriorate suddenly and come to you, and this may be triggered by new arrhythmias, which can often be in mitral stenosis or mitral valve disease, a development of atrial fibrillation. Even in aortic stenosis, where the atrial kick forms a very important part of ejection, pumping the blood into the aorta, into the LV first, the failing of the LA itself may be responsible for worsening of a symptom in atrial aortic stenosis. On top of that, rheumatic carditis, infective endocarditis, volume overloads like anemia or pregnancy or infection or sepsis, or sudden rapid IV fluid transfusion, like a lot of times the patient feels weakness and he ends up getting IV fluid by some local practitioner without knowing his cardiac status, can actually cause a worsening because the heart is already working at a peak of the Frank-Starling curve and can't accommodate more flow. Now, to understand the symptomatology and also the clinical examination, you need to know the basic hemodynamics of various chambers. Once you know these, then you can corroborate your findings based on the JVPs or the right heart examination or the left heart examination or the symptomatologies or development of PND. All of them will corroborate with certain hemodynamic parameters. The right atrial normal mean pressure is 3, right ventricle is 25 peak and 9 diastolic. Pulmonary capillary wedge is 9, range is 4 to 12. This is important to remember. Systemic vascular resistance, roughly you can remember as 10 Wood units and 10 to 20 Wood units, and pulmonary vascular resistance in 1 to 2 Wood units. So Wood units, when you convert into dyne centimeter to the power minus 5 of second centimeter to the power minus 5, you need to multiply Wood units by 80 to convert it into the standard IS units. So PVR would be 80 and 80 to 160. You can say PVR is 1 to 2 Wood units is normal, and 10 to 20 Wood units of SVR is normal. Now we have to understand what happens in all of these conditions. Let's start one by one, and we'll just first discuss the mitral stenosis. The first thing that happens in mitral stenosis is the development of stasis of the blood in the LA, and the atrial kick actually causing the LV to fill in the later part, and presence of a end diastolic transmedial gradient is pathognomonic of mitral stenosis. So there should be some gradient left even if it's a clinically mild mitral stenosis at the end of diastole. You can have gradients in between, but that does not pathognomically diagnose a mitral stenosis. So pathognomonic find or hemodynamic pathognomonic finding in mitral stenosis is end diastolic transmitral gradient. Beyond that, what happens is usually in mitral stenosis is the LV end diastolic pressure usually becomes low because of the same, because the flow being impaired, and the LA pressure starts rising. Of course, with the chronicity, pulmonary arterial pressure will also vary, and so it will vary according to the reactivity that may be present, which is very different in certain patients as compared to the other. Like you would find juvenile mitral stenosis, where the pH, where the MS is present and the pH can develop very rapidly, versus vis-a-vis certain patients in Caucasians, where the chronic disease only leads to presence of development of pulmonary arterial hypertension. So bronchoreactivity and not only vascular reactivity, just like bronchoreactivity, also determines what the PA pressure is going to be end up with. And of course, RVSP goes along with the PA pressures. RV end diastolic pressure is often reflected of the development of RV dysfunction in the chronicity of the disease. And as the PA pressure remains sustained and the RVSP is high for a long duration, you'll end up having development of early RV end diastolic rise in the pressure, and then later on development of RV dysfunction. Of course, the RA pressures will be determined by this secondary or organic TR that develops along with the pulmonary hypertension or presence of organic tricuspid valve disease. And of course, the RV end diastolic pressure rises once the RV fails. Compare this with chronic compliant LA, chronic MR as we call it. Because of the compliant LA, LV end diastolic pressure seldom rises unless the LV dysfunction supervenes. Because of the regurgitation in the compliant LA, the V will be more than the A. This is the classical MR that you find when you get patients who have been subjected to cath studies. But you'll also find very super dominant V's when you create an MR accidentally while doing balloon mitral valvotomy. That's how you know that you've ended up actually creating an MR in cath when you're doing a PTMC. So PA pressure will be determined by LA compliance. It's only when the LA starts failing to accommodate the regurgitant jet and the severity overwhelms it that the PA pressures are now reflected back into the LA wedge and then into the PA, and then the PA leads to right in the PA systolics and in the RVDP and development of TR. The various mechanisms how the PA pressure rises in presence of the rising wedge pressure have also been asked often in the question in the exams. So primarily, it's not only the direct transmission of the LA or the wedge pressure into the pulmonary circulation, because it will not otherwise reflect into the suprasystemic PAs that you sometimes get in rheumatic heart disease of the left heart. But the other two mechanisms that are often responsible for the same include one, hypoxia-induced vasoconstriction in the pulmonary vascular bed, and secondly, the thromboembolic or microthromboembolic occlusions that can happen or ensue often with or without atrial fibrillation in these vessels, leading to rise in the PA pressure. So vasoconstriction, hypoxia mediated, or protective vasoconstriction, because when the pulmonary capillary wedge rises and there is interstitial and alveolar edema, as a reactive mechanism to prevent the flooding of the lung fields, the pulmonary arterioles will constrict to decrease the pulmonary blood flow, and this will in turn lead to development of PA pressure. So these are four mechanisms primarily: direct transmission of pressure, vasoconstriction by hypoxia, vasoconstriction to prevent the flooding of the lung fields, and third, of course, is the microthrombi and emboli, which can lead to development of pulmonary hypertension. In aortic stenosis, however, the LV-EDP usually remains normal because it's a supercontractile LV. LA pressures are slightly only raised. PA pressures remain normal unless the ventricle fails. And same is the case with RV systolic and PA pressure. RVDP, when it is raised, either it's a multivalvular disease or it's a Bernheim effect now with the LV impinging on the RV, which leads to rise in the RV-EDP and the failing of the right ventricle, and hence the biventricular failure. But again, it's very rare and terminal, and RA pressure is often normal. So narrow pulse pressure and raised left ventricular systolic pressure are the hemodynamic findings of aortic stenosis. Now, we all understanding all these pressures in the chambers primarily to reflect them into the findings that you expect them in examination. In chronic AR, LV end diastolic pressure rises, and this is because of the double flow that the LV takes, and that's why the LV dilates, as we know from the Laplace law. You have flow coming from the regurgitant jet, and you have the flow from the next cycle from the mitral valve itself, and this in turn will cause the LV to dilate as a volume as a compensatory mechanism to maintain the pressure loads, and hence the LV-EDP usually is raised to some extent but is compensated initially by dilatation. Once the ventricle starts failing, EDP will start rising further, and the wedge pressures are usually normal or mildly raised. PA pressure, RVSP, RVDP all will remain normal unless the Bernheim effect, as I mentioned. And of course, the RA pressure will remain normal, and pathognomonic finding would be signs of white pulse pressure. Now, how do you determine a dominant lesion? Dominant lesion can be determined by 9 important parameters of examination, including symptomatology. First is dominant symptom. So whether it's the aortic symptom or a mitral symptom, a stenotic symptom or a regurgitant symptom. Second is the duration of illness, because this we know from the natural history, how certain severe diseases of certain valves will not allow a natural symptom-free survival for beyond certain period of time. Third is the character of the pulse, blood pressure, JVP, which primarily reflects the right heart, of course, PA pressure or pH findings, apex beat, first heart sound, and murmurs. So these are the findings based on which you will rest and define which of the lesion is a dominant lesion or a multivalvular, which of the lesion you would say severe and the other one as a bystander or a moderate lesion or a mild lesion, etc. First is the cardinal symptom. The mitral stenosis, as we know, primarily has got symptomatology defined in terms of dyspnea, cough, and palpitation. So dyspnea, cough, and palpitation. Palpitation in mitral stenosis can be either atrial fibrillation, which is very often almost 30 to 40% develop beyond 5 to 10 years of the involvement of mitral valve disease or development of mitral stenosis. But sinus tachycardia per se can also be responsible for the palpitation that a patient can feel. Right heart failure again can be a rare finding. Regurgitant lesion manifests by fatigue primarily, because the regurgitation is there. So there are 2 outlets for the ventricle. So one outlet is the leaking of the valve leading to the flow going to the either the LA in MR or into the LV in the AR, but the other competitive flow is to the systemic circulation. Now, because there is deprivement of the flow, there is a reflective or compensatory vasoconstriction in certain beds with preferential flow to the more vital organs. And hence the blood is primarily dilated and going towards the important organs like brain, kidney, heart, etc. And the muscles are deprived of the flow for whatever the amount is deducted from the regurgitant fraction. So that is the compromise that the muscles will have to ensure, and hence the symptomatology of fatigue comes into the patients who have regurgitant lesions. Palpitation is because of the volume overload that the ventricle has. The double flow from the regurgitant jet and the next cardiac cycle both will make the preload to increase in the ventricle, and hence the force of contraction will be more, and this increased precordial activity or the increased force of contraction without an increase in the rate is often reflected by patients as palpitation. But his symptomatology, we have to dig it into and find out whether he's talking of dil jaldi dhadakta hai, tej dhadakta hai, ya jor se dhadakta hai. If it's beating too hard or it's beating rapidly. So forceful contraction, which is precordial activity as often defined as, is often mentioned by patients as palpitation. But as an examiner, as a cardiologist, you need to differentiate what he's trying to say, whether he's talking about increased rate, which is the palpitation, or whether he's talking about increased precordial activity, which is forceful contraction because of a regurgitant lesion. So these 2 important symptomatology tell you that you're dealing with a regurgitant lesion. We know classically aortic stenosis deals with angina, syncope, and failure, with the Brunwald series mentioning a median period of 5, 3, and 2 years. In aortic regurgitation, angina, palpitation, fatigue, syncope, and lastly failure can also be the symptom, predominantly cardinal symptoms. Now, based on these, you can come down to what symptoms or what lesion primarily you're dealing with. Suppose a patient has come with right heart failure and the history of duration is say more than 10 years, you're sure that you're dealing with something like mitral stenosis, at least, which has been responsible if the organic tricuspid valve is not involved. Otherwise, of course, you can have symptoms like angina and syncope. So syncope, though can happen with arrhythmias, and fast AF can cause syncope, emboli can cause syncope, but transient repeated no residual syncopes would go again in favor of aortic stenosis, which is very classical of it. So once you have defined from symptomatology as to which valve you are suspecting, you look at the natural history of how long the duration has been. We know from the Rose series that the mortality at 10 years in mitral stenosis would be for functional class varying from 15, 58, 85, and 100%. So If the patient has been in class 4, say for 10 years, you're not dealing with mitral stenosis. You're dealing with something else. You're dealing with maybe a CTPAH, maybe you're dealing with an ASD, but you're not dealing with a mitral stenosis with 10 years history. But very importantly, compared to the other valvular lesions, it's the mitral stenosis that gives you the longest duration of history. Because once you're class 4, in natural survival of more than 4 or 5 years would never fall into any other regurgitant lesion. You can still have some survival with class 2 and 3 in patients with mitral stenosis. As I mentioned, almost 10 years, 58 and 85% mortality. So you have 15% survival and 42% survival for class 2 for 10 years in the subgroup. Again, as I mentioned, 10-year mortality, if you look at the mean age series, and 52% were asymptomatic in Rose series, 10-year mortality of 39% for all comers, if you don't look at the functional class, and 20-year mortality is 79%. So somebody who's been like, say, 10 or 20 years, is more likely to be a mitral disease than any other disease. Olsen series has also the similar data. You can see 10-year mortality of 70%, but here the patients were older, 42 years, and of which 86% was symptomatic at the onset. So once they are symptomatic, 10-year mortality goes to 70%. And Rappaport series, 10-year mortality was 60%, and most common cause, of course, was congestive cardiac failure followed by thromboembolism. While we compare this with mitral regurg, 5-year survival in symptomatic patient who refuse surgery is only 30%. And in MR due to flail mitral leaflet, annual mortality is 6.3%. Again, going on to say that probably around half of the patients will not survive beyond 5 years. So once you have symptomatic MR, again, in history, when you look at a mild then it's a mild MR, then it's an excellent prognosis. But if you're dealing with severe MR, 10-year survival in Rappaport series was 60%, 46% in Munch series. And when you look at the mitral leaflets, mitral leaflets, 10-year survival is 57% in Lingetol, and symptomatic MR 5-year survival is only 30%. So any MR and dyspnea that comes, say, beyond 5 or 6 years, dominant MR becomes very unlikely. It's not that it doesn't happen, but these are median survivals. Now, as we know from Grunwald series, 5, 3, and 2 for AS, and 4 and 2 for AR. For AR, angina is 4 years, and failure is 2 year survival. So again, a patient who's come with failure and has been there for more than 2 years, you're practically assuming that it's not dealing with a case of isolated aortic valve dominant lesion. You probably have a MS, which has actually helped him live through some amount of PNDs and some amount of failures beyond this duration. So duration of the disease will also tell you a patient who's syncope more than 3 years. Again, you probably think that you're dealing with some. So symptomatic AS actually tend to worsen and rapidly progress. As you know from the natural history of AS, that in 10 to 15 years, once the latent period is gone, 2.5% over 8 years, they will develop severe AS. And in Grunwald-Ross series, patients with angina syncope had this median survival of 5, 3, and 2. Progression again varies by 1.2 centimeter per square per year reduction in AS, with Vmax rising by 0.32 and gradient rising by 7 millimeters per year. In Rosen-Hack series, the valve area, when you look at the valve Vmax values, based on that, your 2 year survival, if you look in a patient whose Vmax was more than 5.5, it's only 25%, which means to say if you have a very critical AS, as it is known as, 75% would be dead by 2 years once the AS becomes very severe or critical enough. For chronic AR, Bono series, which had about 58 plus minus 9% alive, asymptomatic over 8 years. You can see that the median survival, they were followed of 490 patients was followed for 6.4 years. And the rate of progression to symptom to LV dysfunction or death is 4.3% per year. And asymptomatic LV dysfunction progresses 1.3% every year, with an average mortality of 0.9%. But what happens once they become symptomatic? Compare a patient. So once you're seeing a patient, it's a symptomatic AR, if it's an AR. So once a patient is symptomatic, the mortality is more than 10% a year. So asymptomatic with LV dysfunction will also become symptomatic at a rate of 25% per year. So once the patient is symptomatic, that's the reason why still we stick to the guidelines. Asymptomatic rheumatics don't touch. Only symptomatics, unless they are severe. And severe, of course, you need to touch, but you need to define them. So that's the whole flowcharts as we know. But that's not the topic of today, what to do, when to do for them, but how to define what they are is what I'm talking about today. So Again, you need to look at the chronicity, the temporal relationship between the symptoms. As I mentioned, dyspnea precedes palpitation and palpitation precedes dyspnea. If dyspnea precedes palpitation, it is that the arrhythmia is induced by hypoxia. So either it's sinus tachycardia or hypoxia-induced atrial fibrillation, etc., which has led to palpitation. While if a palpitation precedes dyspnea, it's probably because of the shortened cycle that you're getting worsening of the symptoms, which very often happens in patients with mitral stenosis. So history can help in identifying arrhythmia as SVT if you have one, based on three things. Two, of course, I've mentioned here. Third one I'll also talk about. So post-arrhythmic diuresis, as people say, it's due to secretion of adrenergic peptide, as people say, and termination of arrhythmia by vagal maneuvers. You can do carotid massage or diving reflex or self-induced vomiting. All of them can cause termination of SVT. Third thing is some people and some papers mention that's the bending forward, which often triggers these arrhythmias. Based on the palpitation, again, you can ask the patient to mimic, as certain books mention, as to how it beats. But irregular, rapid onset, rapid offset is something that goes on favor of atrial fibrillation. Gradual onset, gradual offset tells you sinus tachycardia, and rapid onset, abrupt termination with regularity tells you another tachyarrhythmia. Again, people can present with vague symptoms like abdominal pain, which can be part of GI symptomatology, but it can be part of rheumatic heart disease itself. This can be primarily driven by stretching of Glisson's capsule because of the right heart disease itself, or the TR or the TS, or congestive hepatomegaly, or right heart failure. Also, digitalis and verapamil, both of them can cause GI side effects. Congestive enteropathy, systemic interleukins, and acute rheumatic fever is a manifestation. All of them can cause abdominal pain. Anorexia can also be can be a symptomatology because of various reasons, like the drug toxicity, impaired liver function or liver congestion, congestive enteropathy, inflammatory markers, and sympathetic overdrive. Now, there is something called as paradoxical dyspnea relief. In patients with aortic regurgitation, actually patient will start feeling better when he walks or exerts. This is primarily because of development of tachycardia. And as we know, as the heart rate goes up, it's the diastole which shortens. Systole doesn't shorten. So the duration of diastole shortens when the sinus tachycardia develops, and hence the patient may actually start feeling better while he exerts. Because of the shortened diastole, the amount of regurgitation in aortic regurgitation will come down, and hence the patient will actually feel paradoxical dyspnea relief. Now, various mechanisms have been attributed to PND, which include, of course, everybody knows about redistribution and absorption of edema fluid with increase in the lung getting flooded by it. There is, of course, the other two important theories that it happens only in the first, and it doesn't happen in the first 1.5 or 2 hours. That's because it's the REM sleep which is responsible to some extent for development of certain arrhythmias and activities, rising in the heart rate, increase in the sympathetic tone, nocturnal arrhythmias, which can actually cause the PND to happen after 2 hours. Sleep-associated respiratory depression and sleep-induced dreams with attendant increased emotional activity are also ascribed as certain mechanisms why PND develops after 2 hours of sleep. Now, there are certain important hemodynamic correlates that we need to understand, because you may be asked, this patient is in PND. What do you expect his chest X-ray to look like? Or what do you expect his wedge pressure to be? So we need to know certain hemodynamic correlates. Once the patient is asymptomatic on routine work, as we call as class 1, the wedge is expected to be below 12. And then the first finding may just be nothing but mild venous edema, hypertension on exertion only. But at rest, the upper lobe redistribution, which looks like an Antler sign, it correlates with the wedge pressure between 12 to 18. And these patients are usually class 2. Once the patient develops PND or is a class 3 patient, wedge pressure rises to 18 to 25, and the interstitial edema is the pathological lung finding, which correlates on chest X-ray with curly lines. Class 4 or orthopnea correlates with a wedge pressure more than 25, and the pathology is alveolar edema, and the X-ray looks like bat swing appearance. So you can be asked anything. Bat swing, what do you expect wedge? Patient is PND, what do you think is the X-ray finding? Something like that. So we know the RHD criteria. I'll just skip that. So in Indian setup, these are the certain things that we need to understand compared to the rest of the world. First, our patients are younger compared to most of the series. Most of our patients will have multivalvular disease, will have multiple recurrences, rapid progression, high incidence of complications like AF, embolism, CCF, or problems associated with prophylaxis and treatment, which is again an issue in our part of the world. If you look at what frequency they are involved, so even if you're bluffing you are more likely to be right that this is a mitral valve disease. The likelihood is 75%. So 3/4 of them will have isolated mitral, and mitral plus aortic will be another 20-25. So if you think your patient is pure aortic, you cross-check it doubly, because very likely the second valve MS is silent. So very likely MS is going to be there and it's getting masked. It's gone into the axilla and the back, as they say, and the aorta has pushed it back and you're not able to hear the finding. Isolated aortic valve, you only get in 5 to 8%. Another thing is that the autopsy series have shown that tricuspid is involved in Indians in almost 1/3 to 1/2 of the patients. Total mitral involvement hence is almost 90 to 92%, and aortic involvement is 30 to 35%. This is from the Feinstein series. Even in Manjunath series in RHD, the order of involvement was 60%, followed in mitral, followed by aortic, tricuspid, and pulmonary, and mitral was exclusive etiology in 98% around patients. Isolated MR was 41%, with MVP another 40%. Again, in this series, MS plus MR was the most commonest lesion, followed by MS with AR, MR with AR, followed by AS with AR, with an MR with AS, and the least common was MS with AS. Now coming to the, after once you've known the symptomatology, the duration, its topography, its temporal relationship, what happened first, what happened later. Once you've arrived at this history, now you come to examination. Once you look at the pulse, we should know what happens and in each of them in characteristically. Mitral stenosis, when it's dominant, you would expect the AF to be present. But remember that the in patients who have distal valve disease, the proximal will always mask the severity of the distal valve disease. So in a patient who's got severe MS in presence of AR, the collapsing pulse may, water hammer pulse may not be so classical at times if the MS is very severe. So mitral stenosis, the pulse apex deficit and narrow pulse pressure are the two findings. MR, of course, you find a collapsing pulse. Aortic stenosis, you have anacrotic bisperience, alternans, parvus et tardus, and aortic regurgitation. Pulse would be the water hammer or alternans in nature. So which conditions you have an AS, in which condition you'll get pseudo-normalization of pulse despite presence of severe AS. So those severe AS, you expect it to be either anacrotic, bisperience, alternans, parvus et tardus, but it may not be so when there is associated AR, hypertension, high cardiac output states like anemia, pregnancy, or patients who have elastic vessels, like patients who are children or very stiffened vessels of elderly. These peripheral signs of AS may be missed. Rapid distal runoff, as they are called, though very often ascribed to AR, but they can happen, a lot of them can happen in rapid distal runoff, like PDA, a large duct, or patients with severe anemia. But certain signs are specific, and these are the complete list of the tests that the signs that I wanted to mention. Alfred D. Musset's, we all know, oscillating, bobbing the head in systole. Lighthouse is blanching and flushing of the forehead. Ashrafi's sign is pulsatile pseudoproptosis. Landolfi's sign is constriction, dilatation of pupil. Baker's sign is retinal vessel dilatation and constriction or pulsatility in fundoscopy. Drummond's sign is systolic expansion of air from the nose when mouth is closed. Buzzolo's sign is pulsatile nasal mucosa. Minervini's sign is strong lingual pulsation. When you press a tongue depressor, it moves up and down. That is what is lingual pulsations. You can see Minervini's sign. Muller's sign is pulsatile uvula. Corrigan's sign is pulsations of the supraclavicular and carotid artery. Luke's sign is sternoclavicular pulsations in patients with AR due to dissection in the aneurysmally dilated aorta. Locomotor brachialis is pulsatile brachial pulsation. Water hammer pulse is nothing but the exaggerated bounding radial pulse, specifically when the limb is in line with the aortics, as we know the Victorian time raising of the hand. Palfrey's sign is the pistol shot in the radial artery. Palmer click is visible abrupt flushing of the palm with systole. Dermatographia is wheel and flare reaction on scratching of the back, and that you find as pulsatile. Penny's sign is flushing of the wheels if there are any on the patient's skin. Quincke's sign is pulsatility in the nail bed, which again you can demonstrate by 3 techniques, which is compressing the nail bed or throwing a torchlight, etc., and a slide. Cutis quincke was described by Holden. This was especially in a child who had a mosquito bite, and that red bite was flushing on pulsation, had a PDA. Rosenbach sign is pulsatile liver. Gerhard's sign is pulsatile spleen. Dannison's sign is pulsations of cervix. Durosier's sign is the combination of systolic as well as diastolic. Durosier's murmur reflects the diastolic. So distal compression causes diastolic murmur, while proximal compression causes systolic murmur. Together, both are called as Durosier's sign, while the distal diastolic is called as Durosier's murmur. Trope's sign is loud femoral pistol shot. Hill sign is accentuation of the leg systolic pressure by more than 20 compared to the upper limb. Pulsus bis variance, you usually find AS with AR, never alone in AR. Lincoln sign is popliteal pulsatility. Sherman sign is prominent dorsalis pedis in more than elderly 75-year-old. Shelley's sign is pulsatility again of cervix, and May's sign is a non-specific sign of diastolic pressure of 15 when the arm is held above the head. So this is the complete list, not incomplete. I assume there might be still more. Blood pressure is the next finding that you'll use to differentiate which of the two is the dominant lesion. In mitral stenosis, the systolic blood pressure usually remains normal. You may be asked when condition you'll get high blood pressure, so you can say hypertension. Renal artery embolism is what the examiners are often interested in asking, because when a patient can have an atrial fibrillation in MS and he throws an embolus into the renal artery, they can develop a secondary hypertension and have a systolic rise in blood pressure. But an uncomplicated MS usually will have a normal or low systolic, a narrow pulse pressure because of the stenosed or atrial kick, and you have a normal diastolic pressure. In MR, it's the mild rise in the systolic, usually normal, but it is the diastolic which is low, and hence you have a wide pulse pressure. That's how it differs from AR, where the systolic pressure is also high, pulse is wide, and diastolic low. So systolic pressure differentiates to some extent MR with AR, but as I said, this is not a golden rule, but this is some of the findings that you can actually corroborate in blood pressure. AS, of course, depends. Most of the times, as a sympathetic response, patient can have high blood pressure, and pulse pressure may actually use usually a narrow one. Diastolic pressure may be slightly raised because of sympathetic tone. Coming to JVP, Lancisi's sign, as it is called, is a clinical sign of a large venous wave or giant V wave, as is visible in jugular vein in patients with TR. So what is called as S wave, the obliterated X and then the prominent V, together they form the S wave, and that S wave is often so called as Lancisi's sign, which is obliteration of X and prominent ventriculization of JVP, as it is called. That tells you that you're dealing with a severe TR. So giant V along with obliterated X called as X wave. And then to differentiate the TS from TR, the TS will have prominent A wave and absent Y descent, while TR will have obliterated X descent with prominent V waves, and the fusion of V and Y can also sometimes be present to differentiate the TS from TR. Now, this is how the JVP is to be looked. You put a light across with the pillow, the head slightly raised, and you're leaning across the patient's chest and throwing the light to parallel to the skin of the neck, and see the movements of the skin of the neck and see whether you're taking a JVP, because JVP is the negative, the away movements are better perceived. The negative waves are better perceived than the positive wave. So it's difficult to assess despite several posture. In that case, if it's not visible, then you have to lower the end of the IGV to you compress in the middle between the two heads of the sternocleidomastoid. And now that the JVP becomes prominent, it suggests that the JVP was too low, and now it is filled up by the obstruction that you've given. If it's still not apparent, then probably the JVP is too high into the neckline and you're not able to differentiate. Pulmonary hypertension, early PH in mitral stenosis and acute MR, it can develop, and terminal PH only you will get in chronic MR. So a long duration of PH would usually go in favor of mitral stenosis. Chronic MRs can also develop PAH, but it's only when the LA compliance goes. But aortic valve very rarely ever have a presence of pulmonary arterial hypertension, barring some exceptions like Bernheim effect or presence of silent MS. That is what you need to rule out. More importantly, if you're getting finding of PH in a patient of suspected pure MF. So signs of PH are large A wave on JVP, signs of right ventricular hypertrophy, that's a right parasternal heave, RV type of apex, loud P2, presence of diastolic shock, RV heave, and presence of Graham-Still murmur or functional TR. So these are the findings based on which you say the PH is present or absent. The etiology of MR can also help you in understand and comprehending based on the sounds. You can differentiate as to what etiology you're dealing with. A wide splitting is very often found in rheumatic MR. A normal split you'll find in MVP with a loud S1 actually. And the paradoxical split will be there in PMD, papillary muscle dysfunction, because of intraventricular conduction delays. So wide split is rheumatic, normal split is MVP, paradoxical split is LVD. This is how you demonstrate parasternal heave. This is how do you put the thenar and hypothenar at the pulmonary area and palpate for the diastolic shock. Now coming to the first heart sound. The first heart sound is usually loud with exceptions of MS. MR, it will be soft. AS and AR will have little impact barring AR, where the regurgitant jet actually pushes the first heart sound. So what is called as the mechanism of one of the older theories of development of Austin Flint, which will be causing the dampening of the first heart sound by opening of the mitral valve being hampered in. So first heart sound, if you find loud, you're dealing with a mitral stenosis, which is the dominant one. You can have even loud S1 in MR. So the causes of that would be tachycardia. In MR of mitral valve prolapse is one of the commonest cause where you'll get loud S1 and still you have a dominant MR. Also, once the patient has got acute rheumatic carditis, the first manifestation may be presence of loud S1 because of valvitis itself. Anemia and thyst chest are the other causes where you can still get loud S1 in MR. Often you're asked, how do you differentiate opening snap from LVS3? Remember that the LVS3 is a low frequency, low pitch sound, which is heard with bell, and it increases with expiration, is often palpable, and the S1 is usually soft. When you will also never have a presystolic accentuation of a murmur, because if that is there, you will never get. While in MS, you will always get a rumble, the presystolic accentuation. It's never palpable. Opening snap is rarely ever palpable. It's primarily the S3 which is palpable. S1 is, of course, something that helps you to guide what you're dealing with. If you have S1 is loud, you're dealing with an OS. If you get an S1 which is soft, you're dealing with an S3. Palpation of the apex. Now, this is the technique which is mentioned in certain books, that you don't palpate, especially the Abrams. This picture was there. This is from, of course, my own picture, but the picture that is there demonstrated in Abrams, the old edition, shows that the palpation of the apex is to be done from behind the patient, with first palpating from the front and then holding the tip, the apex beat with the tip of the middle finger from the behind, and then palpating it. So the characteristics of the apex beat, the presence of MS, it will be tapping in character. Tapping is just touching and going, which never lasts. The amount of the LA kick that comes into LV is hampered, and hence the normal characteristic, which is so-called just tapping, becomes tapping. Then it's slightly shortened than otherwise it is. That is what a tapping characteristic is, though people call it to correlate with loud S1, but it has been proven that it's never got to do anything with S1. Mitral regurgitation, in the volume overloads, both the volume overload, it will be forceful, but not sustained. So when you mean it by forceful, the lift is forced. You can perceive it very well, but it does not go beyond 1/3 of systole. So 1/2 or 1/3 of systole, which means if you're putting a stethoscope there, your lift is gone before the second heart sound comes. That's how you can differentiate. So hyperdynamic you find in two regurgitant lesion. In pressure overloads, in volume overloads, you get hyperdynamic. In pressure overloads, you get heaving. So pressure overload you'll get in aortic stenosis, and you get it even in RV heave in PS, or you get PAH causing RV heave, or AS causing LV heave. So heave is basically a pressure sign, and hyperdynamic is primarily a volume sign. So based on this, again, you can differentiate. Again, you can get heaving in AR when the LV dysfunction supervenes. So any LV dysfunction will cause development of heaving type of apex, though those lesions are primarily determined by their hyperdynamic character. But LV dysfunction with a rise in the LVDP and delayed IV interventricular conduction time and prolonged contraction time, all of them can cause the apex beat to last up to second heart sound, hence giving an impression of heaving in character. The murmurs that will determine the severity or the lesion will be the A2OS interval and the length of the mid-diastolic murmur in MS. Presence of mid-diastolic flow murmur in MR will also tell you that you're dealing with a severe MR. The loudness of any murmur, if it tells about severity, is the murmur of MR. MR is the only murmur where the severity of the murmur can reflect the severity of the lesion. All other places, the intensity of the murmur does not matter. The length of the murmur matters. The longer the murmur, more severe the lesion. MR is the only condition where the length of the murmur is always pansystolic. It's the intensity which has got some value in determining severity of the lesion. Of course, you can look at the radiation extent. A wildly radiating murmur from the apex to the, say, the base or to the posterior aspect would also reflect that the MR is very severe. Aortic stenosis, it's a long late peaking or late peaking of the murmur, which tells you aortic stenosis. It starts immediately with the cardiac systole, also tells you that you're dealing with a severe AS. A long murmur again in AR and presence of Austin Flint murmur will also tell you that you're dealing with a severe aortic regurgitation. So when you compare, you may be asked the difference between MS and Austin Flint. You have to remember that once you have MS, the Austin Flint actually goes on with severe AR, and the finding would be that of AR. In MS, you'll have findings of the PH. So findings of the MS would include atrial fibrillation, failure for more than 5 years, as I mentioned already to you, because a failure of 5 years in AR is very rare. LA enlargement, LA enlargement will be in MS, and LV enlargement will be there in AR. You will have RV heave because of PH, loud S1, opening snap present in MS, S3 present in Austin Flint. Of course, one of the uses of amyl nitrate has been mentioned as decreasing in the murmur of Austin Flint because of peripheral vasodilatation, and peripheral signs of AR would go in gain favor of aortic regurgitation. Again, MDM of MS versus MDM of severe MR can be differentiated by presence of S3, murmur that ends before first heart sound. In MS, MDM of MS, it can last up to first heart sound, while presystolic accentuation is always favor of mitral stenosis. You will never get presystolic accentuation in flow murmurs of severe MR. Presence of thrill is again diastolic thrill in a favor of organic lesion, and hence it's a mitral stenosis. And if the findings of associated MR, a systolic murmur is present, that will also be an indication to tell you that you could suspect a severe MR to be responsible for causing a mid-diastolic murmur in mitral regurgitation. Sometimes you may be asked that the patient of mitral stenosis has developed edema, ascites, pain in the right hypochondrium, and has never developed any breathlessness. He comes to you with severe MS. What do you suspect? It's of course the organic tricuspid disease. As I mentioned, 1/3 to 1/2 of Indian patients on autopsy series show organic tricuspid disease. Again, same question. A patient of aortic stenosis who's been having dyspnea for more than 3 or 5 or 7 years, what do you suspect? It's a silent mitral stenosis, which is present and is masked by the aortic murmurs predominantly, and the silent MS is on the back, and that's protecting him. So this was the old clinical classification of mild, moderate, and severe. Now the definition is just severe or critical or significant MS, as they call it. But this area of 1.5, 1 to 1.5 and 1 was used and still is being used by echocardiographic societies, though the clinical classification now talks about severe MS, critical MS, and mild MS. So this distinction of mild, moderate, severe, though the old-timer teaching was there, it can still be arrived at by looking at the clinical symptomatology, whether the PND is present or not. Hemoptysis, though it's absent in mild, but can be present both in moderate and severe. Atrial fibrillation can again develop much early in moderate MS, but right heart failure, findings of PH, all will go in favor of severe or moderately severe mitral stenosis. So low volume pulse, narrow pulse pressure, low cardiac output, JVP, which has prominent A waves, short A2 OS interval, long mid-diastolic murmur, palpable P2, Gram-Stell murmur, and presence of RV heave, all are feature of severe mitral stenosis. How do you determine, or what are the findings that show severity of MR? Widening of the A2P2 interval, presence of loud P2 in absence of MS, loud palpable S3, presence of mid-diastolic flow murmur across the mitral valve because of the regurgitation that happens in the MR, bringing back the increased flow from the previous cycle, and the regurgitant blood, both coming through the normal mitral valve, will behave as if the valve is behaving like a stenosed valve, and hence there will be presence of MDM. There is also brisk carotid pulse, presence of thrill, presence of AFib, downward displaced apex with sustained, as I said, once the LV dysfunction or high volume starts rising, you can have sustained apex, and it tends to behave like a heaving rather than hyperdynamic. Again, tells you that you're dealing probably with a severe MR. Loud intensity murmur, early or late parasternal pulse, which reflects these what is called as LV rock. So LV contracts and LA lifts. So if you can get the LV rock between the rocking between the LV and LA on the precordium, you're dealing with a severe MR. Severe AS can be suspected by palpable A wave, or so-called a presystolic impulse of the apex because of the atrial kick, because that's very important aspect. It can generate so high of almost, people say 40 to 50 millimeters of mercury rise in the contribution sometimes in patients with AS. Paradoxical splitting of second heart sound is one of the important finding in AS because of the prolonged cardiac cystole. The A2 may get delayed to beyond from the P2, and hence you can have a paradoxical split. Presence of S4, parvasit tardus is the only characteristic pulse which tells you severity of AS. You can get all kind of pulses, but it's the parvasit tardus which correlates with severity of AS. Late peaking of the murmur, long duration of murmur, narrow pulse pressure, though it's a non-specific sign, a systolic blood pressure more than 200, it rules out as practically severe AS. So a patient who's come with a blood pressure of 190 or 200, you cannot be generating a severe AS LV systolic of 230. This is superhuman. So LVs don't generate that much of pressures to generate a severe AS and a high blood pressure of 200. Apicocarotid delay, if you can perceive it, then the valve area is definitely very critical. Long S1 ejection click duration, all of them are finding of severe AS. Presence of each of the first three individually suggests gradient more than 70. So either you have A wave, split second heart sound, or S4, all of them will happen when AS is more than 70. Systolic thrill does not indicate severity in AS and is a rule rather than and more common in associated AR. Gala-Verdin dissociation versus MR again is a differential that you need to keep in mind. Gala-Verdin is basically you will suspect in patient if there is a carotid delay, there is radiation to the carotids or the murmur. Amyl nitrate will increase its intensity while the murmur of MR will disappear or decrease. VPCs will change the intensity of AS, but murmur of MR never changes with intensity because it's pumping into a low pressure chamber, which is the LA. A2 is soft while A2 is normal in MR. Base of the heart ends with the A2, that's the site of the murmur, while it ends with the S2 is what the murmur of MR would look like. Typically carotid pulse, you can differentiate based on that whether dealing with AS or MR. Associated features like apex beat, pulse character, S3, soft S1, MDM also differentiate the two. Severity of AR can be judged by people often say by Hill's sign, which is more than 60 millimeters of mercury, presence of the long diastolic murmur, Bisperian pulse, soft S1, presence of Austin Flint murmur, presence of peripheral signs of AR, diastolic pressure less than 50 in presence of elevated systolic is often mentioned as one of the signs. Sustained apex, as I said, which is down and outward. Now it's because of the development of high LV and diastolic volume, and you can now have development of early LV failure. You can get a heaving apex now. And presence of LVS3 or presence of ejection systolic murmur, all are feature of severe ART. Then you sometimes can be asked what is diastolic MR and what is systolic AR. The common causes of that you need to know. Diastolic MR develops in acute AR because the pressures are always so high. Development in the acute AR that a non-compliant LV will allow the blood to actually regurgitate into the mitral through the mitral orifice. And sometimes you can get diastolic MR even in LV dysynchrony because of non-coaptation or non-synchronous coaptation of the two leaflets, and that's what you tend to correct with CRT. Systolic AR develops in ECMO. ECMO is the commonest place where you should decay. You also can get it in sometimes in AFib because atria is contracting at a different rate and ventricle at the separate rate. Even palliative correction of complex congenital heart can have a residual systolic AR, and severe LV dysfunction with AR can also have AR all across the cycle, and hence you can have both systolic or diastolic AR as is mentioned on echocardiography. Primary PR from Graham's cell. The Graham's cell you need to know because that's one of the important signs of PAH. The very classical finding is that it starts immediately after second heart sound because of high pressure. So it's a high pitch, starts immediately after P2. There is no pause between the murmur and the second heart sound. And the P2 is loud. These three features will tell you that you're dealing with a Graham's cell a murmur, and it's not a primary PR murmur. Diastolic shock hence is present. Vascular ejection click is present, and RV heave is also present. All are findings of the pulmonary hypertension. Acute AR versus chronic AR, you can differentiate based on the onset, whether it's early, sudden, or late or insidious. Pulse pressure is wide in chronic. Systemics, the systolic, diastolic pressure will also be hence be abnormal. SVR will be decreased in while it will increase in acute AR because of sympathetic tone. LV apex will become hyperdynamic. S1 will be normal. P2 will be normal, but S3 will be uncommonly present in chronic AR. But chronic acute AR will always have an S3. AR murmur will usually be long and high pitched. In chronic AR, grade is more than 3. Austin Flint is present. ECG and peripheral signs and X-ray all will be present only in chronic AR. AS versus systolic flow murmurs of AR is another differential. You have a severe AR and then you have a mid-systolic flow murmur. These are rarely associated with thrills. The thrill will tell you that you're dealing with an AS. It peaks in late systole, while early peaking is common in patients with AR-associated flow mid-systolic murmurs. of the flow. More commonly associated with aortic thrill goes in favor of AS, and peripheral signs are absent, while you'll find definitely presence of peripheral signs of AR in patients who have systolic flow murmurs of AR. Organic versus functional TR is sometimes that you need to differentiate. When you mention that patient has got PR murmur, you'll have to tell whether you're dealing with an organic tricuspid or a functional TR. So how do you differentiate is by looking at the V waves. In functional TR, you'll go in large V waves, but these are normal in organic because of the stenosed tricuspid disease. The regurgitant jet is accommodated by the RA, and JVP is not reflective of V waves in these patients. But it's generally elevated because of the functional TR. Very organic, it may not be actually elevated because these patients are already on diuretics because of their decongestion that is required for the GI symptoms. TR murmur is very often heard because of the pressure, high pressure in functional TR. But organic, the gradient, as you know, is very minimal. The murmur may or may not be heard. But very importantly, inspiratory increase is present in organic TR because these small changes in pressure by respiration or leg raising or volume changes will reflect the change in the intensity of murmur where the pressures are normal. So that is in the organic TR. But functional TR, where the pressures are systemic pressures, the small changes by leg raising or volume changing or respiration will not change the murmur intensity in functional AR. So hepatomegaly edema are findings of organic TR. Severe TR is reflected by head bobbing, proptosis, systemic pulsation of earlobes, hepatomegaly, pulsatile liver, ascites, and engorged neck veins. So Kericum murmur, sometimes you can suspect, which cause pansystolic blowing murmur associated with mid-diastolic murmur. Remember, Kericums is a murmur which is short mid-diastolic murmur, loudest at the apex, and usually associated with MR. So you can't expect a Kericum without a severe MR. So it's caused by valvitis, and severe MR is a prognostic significance because in long term it's going to cause a problem. 2 to 8% of silent carditis, which is beyond the topic today, which you can pick up on echocardiography. And once you have looked at the patient, based on these symptomatologies, you can arrive at what is the dominant lesion, what symptom you're dealing with, and this further you can confirm by ruling out rheumatic activity. Look at the ECG. ECG, what is most important is looking at the axis rather than look at the rhythms, and least you look at the chambers. So chambers don't tell you the dominant lesion, axis does. For example, in mitral stenosis, an axis which is on the right side, more than 60 degrees, tells you that the valve area is less than 1.3. If axis is less than 60 degrees, the valve area is more than 1.3. If your axis is between 100 and up to 110, you're dealing with a systemic PA. Up to two-thirds of the systemic. If axis is 150 up in mitral stenosis, you're dealing with a suprasystemic PA. So axis is more important in ECG, then comes your rhythm, and then comes your chambers. In chest X-ray, however, again, you need to first focus on venous hypertension and arterial hypertension, then look at the chambers, and that links the diagnosis. Of course, I'm not saying chambers are not important, either of the chambers, but you need to look at the axis and rhythm and also look at the chambers. And echo you need, of course, will confirm, and cath if required can help you. These are the various references. Thank you very much. Thank you for inviting me, Dr. Mohit, Delhi CSI, for giving this opportunity to talk about this topic. Thank you.
Thank you, Dr. Kamal, for a marathon and rapid presentation. I know you cannot actually do justice to rheumatic heart disease in 1 hour, and it was my request that we can limit to this particular time. But especially the hemodynamics part and many other concepts which you clarified, and the marathon list of AR signs which even I was not aware of, that was really interesting. And we have a couple of questions that are coming up, and I think Dr. Sumod is already ready with some, and Dr. Girish is also. One of the questions that coming up is that, is there a cause of angina? Can this MR lesions can also cause angina like AR? And this probably was discussed last time when Dr. Rama was presenting, and Dr. S.C. Manchanda, using his old wisdom, he said that yes, this is definitely observed for the residence purpose, that angina can be seen in the patients of MR also. Another thing that I would like to say is that one of the commonly asked things are series on juvenile rheumatic heart disease, which are very, very important and pertinent from the Indian point of view. So what is your opinion on that?
Yeah, so juvenile mitral stenosis is a very important aspect. I did not cover because my purpose was to deal with multivalvular only. So if it was like only mitral, I would have just continued with that, but I had to restrict in 1 hour as to how to determine the dominant lesion That's why. But yes, there are lot of series. Dr. Agrawal coined it, and then there was from SB Roy coined it, and then the Dr. Agrawal series came, and then people have confirmed how it differs from the other. There is another series recently, I assume, published from your center or somewhere from North only. There is one series about juvenile mitral stenosis, has its prevalence decreased. So that again is another important paper published 1 year back, which again says that it's not so different, vastly different, and the numbers are actually going down. The rheumatics in juveniles are actually going down. That's one paper of recently. But of course, how it differs is a very important thing. These patients usually are in sinus rhythm. They are usually balloon pliable. These are minimal calcified lesions. They have a lot of PA pressures, which are elevated, and most of them will stay in the without much of the cardiomegaly, and then you can do a second PTMC and a third PTMC and just keep on going on that. So that juvenile mitral stenosis, that in the original definition of 20 and 18, I think that all have been discussed in various series.
So you are right. Just to add on that, this was a landmark paper which was published by Dr. Sujoy B. Roy. Very authority. It was published in Lancet. So all the students who are going for the exams and preparing, you must go through this beautiful read. Where around about 8 very nice features. Some of them were mentioned by Dr. Sharma, and they were listed. And you should be aware of this whereabouts of this paper. You should be able to quote this paper in exams. This is very, very important.
Yeah, this is one of the favorite question of a lot of examiners.
Yeah,
they think if you know this, if you don't know this, you can't be DM. So I think it was one of the first few publications from cardiology fraternity in Lancet-like journal in those 60s. I think you were talking of.
Yeah, it was long back. It was,
and then I remember myself being asked at Pant only when I appeared for my DNV as to who was SB Roy, and I said he was, and I said he was probably a fellow from AIMS, and he said, no, you don't know. He was not a fellow. He was just a medical officer, and that's the kind of research he could do. So, that was very tempting to listen to, that he was never a faculty or a professor in cardiology who published it when he published. I don't know. He was just a medical officer working in Delhi Corporation in some clinic or something. And then, of course, Dr. Agrawal modified the definition from 20 to 18, and then there was a second paper published about it.
Dr. Kamal, one question which comes to mind is why there is discrepancy in involvement of valves in rheumatic heart disease? Because mitral valve is the most common valve which is involved, and pulmonary being the least.
So why? I mean, I assume your question. Yeah, this is again a commonly asked question as to why mitral is involved more than the aortics, then followed by tricuspid, and very rarely ever the pulmonary. Yeah. So there are various theories that people propose. Of course, there is no proof. One is the deoxygenated blood in the pulmonary circulation with a low pressure flow gradients across the pulmonary valve. So the PA systolics, when you have to look at a chamber, look at that chamber's pressure differences between systolics and the diastolics across that valve. The biggest difference that lies across the mitral valve. You have LV systolics and the LA means. When you compare this with the aortics, you will have not that much of the load of the aortic side, because the aortic diastolics and LV end diastolics are much lower. This is one theory. Second is the oxygenated versus non-deoxygenated blood being responsible. Third theory is the makeup or the architectural construction of these valves, how they differ between between the aortic and pulmonary valve versus the bicuspid and the tricuspid valve. So the cross reactivity that they assume that the various components of the in the acute rheumatic fever that ensues may be responsible for different composition of these valves, for the mucopolysaccharides or the kind of myosin that may be responsible as a component of cross reactivity, etc. And hence they might be more involvement of the mitral and tricuspid and less of the aortic and pulmonary, and rarely ever pulmonary.
Thank you, sir, for that comprehensive presentation. Sir, you were mentioning about palpating the apex in the standing position. What about palpation of the apex in the left lateral position, not for the location, but for the character?
I agree. Yes. So I think palpation of apex has to be all the three methods: supine, with hand, left lateral when you get the thief, and palpation from the back. Again, my own DNB exam, this is 20 years back. I did the first two and did not demonstrate from the back. And the examiner was so furious on me. You don't know, haven't you seen the picture in the textbook? I said, no, sir, I know it's to be done from the behind. So I think the examiners are looking at you to actually come out with what they anticipate you to actually end up missing. So what we actually tend to miss out is the palpation from the back. How it helps is it actually helps you to localize the apex precisely with one finger. When you do a left lateral palpation, you are actually not localizing with just one finger. You are supposed to localize with the tips of the three fingers. And then you see where it is hitting you the most, how wide it is, how diffuse it is, what is its character, is it hyperdynamic, is it heaving? While in palpation from the back of the apex, you tend to localize with the tip of the middle finger, just one finger, and feel the exact characteristic of the pulse. So thrills are better appreciated at the apex by the left lateral, especially the mitral thrills that you get of mitral stenosis. You might have to actually palpate by the left lateral decubitus, but palpation from the behind may be more important for character of the apex rather than the thrills or the other aspects of apex beat characteristics.
One important challenge when there is multivalvular disease is the presence of AF. We have this long cycle, short cycle. So how do we, can you, sir, give us some tips how to, assess the murmur in the long cycle, short cycle, and what is the relevance of the duration of the murmur in the different cycles?
Yeah, so in mitral stenosis, when the murmur will depend on the transmitral gradient that you'll have. If the previous cycle has been short, that means the LA has not emptied completely or has emptied very little into the LV, not only because of the mitral stenosis, but also because the cycle was short. And hence the LA pressure will remain high when the second cycle begins. And hence in the long cycle that follows, you may actually end up getting a long murmur despite not having such a long or severe mitral, not having such a severe mitral stenosis. Hence, if you find a long murmur, mid-diastolic murmur, and sometimes people say you can even get pre-systolic accentuation when a long cycle follows a short cycle in mitral stenosis despite AF. So in AF, you usually pre-systolic accentuation disappears, but you can still get it in a moderate mitral stenosis or even severe mitral stenosis because of the increased gradient that may be persistent. So for severity to assess, you will have to look at a not such a long cycle after a short cycle. You do assess them at a long cycle, but not immediately one that follows a short cycle. So when a long cycle is not following a short cycle, if you can still find a long murmur, you're dealing with a severe mitral stenosis. But when a short cycle, after that, when you get a long cycle and still you get a long murmur, don't be misled by severity of mitral stenosis. You may get a long murmur, not because it's a severe mitral stenosis, but because the previous cycle was short and hence there was enough gradient to give you a long murmur. So ideally, you would not pick a long after a short, you will pick up a long and a long.
Any hemodynamic correlation of PND?
Yes, so PND, there have been certain papers. Recently, there is a paper from, I think, published in the JACC, which also looked at the symptomatology of bendopnea, where they looked at the wedge correlations, but they did not correlate much with the PND. PND, one of the papers was about the Curly lines and wedge pressures and symptoms. So they found out that 70% of the patients who had PND had a wedge more than 18. So 18, some people say 20, some people say Curly A lines correlating with 20. Some mention 18 to 25 as a wedge when the PND usually correlates. So once you get a PND, that's the one of the reason why PND is often categorized as a hemodynamic equivalent of class 3, because the class 3 patients would also have a wedge between 18 to 25. And PND is also likely to happen between 18 to 25. And you'll also correlate this with the development of Curly B lines on chest X-ray. So 18 to 25 of wedge and with presence of Curly lines was documented in 70% of the patients who had PND and had class 3 symptoms in 70% of the patients when the wedge was more than 20. So this was one of the paper. Another paper where they looked at the bendopnea thing, which was coined a couple of years back, 1 or 2 years back. They again looked at the wedge, and there the wedge pressures did not much correlate with the functional class, but they correlate with the bendopnea per se. So bendopnea patients were more likely to behave like class 3 or class 2, but those who had a higher wedge were more likely to end up with worsening and ending up with PND or class 4. So that was another hemodynamic paper for the bendopnea, which was recently coined terminology amongst all apneas.
So all the fellows can go and read these two seminal papers which were released on bendopnea, and especially the hemodynamics of heart failure. Both are published in JACC. I think
Correct.
we shared that. So you can go through them and read the hemodynamic correlates. Anything else, Dr. Sumod and Dr. Grish, or close? Yeah.
They have asked for most specific sign of AR, most often repeated question.
Yeah, so it was again, there is another paper, though examiner expects you to answer Duruzier's murmur as the most specific sign and Hales as categorizing the severity but not a specific sign. But again, there is a paper which tells you that Duruzier's is not very specific sign. Duruzier's you can still get in other disorders like say anemia or a PDA. But in exam, if you are asked amongst the signs that are listed, Duruzier's you can say as specific. Hales you can say as good sensitivity for categorizing the severity. All other signs can happen in any condition where there is a rapid distal runoff.
Hales has also been the center of controversy.
A lot of controversy. They say Hales is falsely 20, 40,
but,
60 is the false.
Often an artifact, but you should know both the aspects so that you can please the examiner according to the way he wants.
Should Valsalva maneuver be performed in a routine multivalvular case to assess or needed?
So Valsalva, usually if you are mentioning class 3 or 4, it's not advisable because then the examiner catches you on ethical issues that you don't want to create a maneuver to end the patient who's just been coming out of class 3 and 4, end up with another episode of failure, and he's supposed to be subjected by another 3 candidates for examination. So don't harass him. So I think ethically speaking also, you should not do a Valsalva unless you are actually suspecting disorders which are going to vary with Valsalva, like an MVP or an HOCM. I mean, if you're suspecting MVP MR or if you're suspecting HOCM, and if you don't do Valsalva, then it's a big problem. Then you'll have to do. But if you're sure and you can justify, sir, because I could make out this is pure valvular, it's not likely to worsen or change much with the Valsalva maneuver, and I've already done other aspects of dynamic auscultation, which is leg raising, standing, respiration. Hence, I have not done Valsalva. Then I think you will be able to save your skin. You don't have to then stick to Valsalva. But if you have HOCM or MVP, then there is no excuse. You'll have to do, even if it's failure and you don't do, then examiner will get annoyed that you've not done that. So otherwise, Valsalva probably is not important, barring that you have a class 2 patient and you want to do a full dynamic auscultation, then you'll have to do it.
One more question which is come up is, will the presence of atrial fibrillation suggest anything about the severity of mitral stenosis?
Now, this is a good question. It does tell you about rheumatic activities that have been there in past, because now there are a lot of theories about it as to that how rheumatic activity per se itself causes development of atrial fibrillation, not just the severity of MS. And there are also certain echocardiographic studies which have defined a cutoff of LA size, which tells you as to what size will correlate with development of persistent or paroxysmal AF. I think it's 40 and 45 millimeters, which have defined as the cutoff, and which we used to study that you don't actually end up, defibrillating patients for persistent AF for LA size more than 45. So it goes more with those rather than severity of MS. It reflects chronicity for sure, because chronicity also, severity also goes with chronicity. Hence, there is a confounding or indirect correlation between AF and severity. But direct relation that a patient has got AF has to have a severe MS that's not true. So moderate or severe MS will often have an MS, atrial fibrillation, but a mild MS may or may not have, depending on associated chronicity of disease and the LA size, that the patient can still develop AF. So it doesn't go in severity, but it does tell you about chronicity, and more chronic a disease, more likely it is to be severe.
Okay. Thank you so much, Dr. Kamal, for a very beautiful summary of approach to valvular heart disease. And I would suggest to all the fellows that you please go and give a good read to the basic chapters in Braunwald, Dallin Elbert, and also on in other different clinical books, so that you can correlate all the facts that Dr. Kamal Sharma has very nicely elucidated. He has his book, which is also published, a much recommended book all across the country. You can also go through all these questions that you were saying in them, so you can get a good ready reckoner for the exam. So thank you so much, Dr. Sumon, Dr. Girish, and thank you so much, Dr. Kamal, for this wonderful session. We will keep on disturbing you in near future. And
My pleasure always,
definitely,
Mohit. Always a
thank
pleasure
you,
to be invited
thank
by
you.
you. Thank you,
And
Dr.
next
Sumon and
week we'll
Dr. Girish.
be next week again on Friday evening. Was an exception. Next week we'll be again joining on Friday evening and continue on Friday evening within the lecture, and we'll be updating you soon about that. In case you have missed this lecture, you want to listen to this lecture again, it will be uploaded on the channel by tomorrow, and you can catch up. I'll also post it in the different groups. Thank you all again
Thank
for
you.
joining us. Goodbye.